Now I'd love to welcome back Swapna and Dr. Winkler. We would love to have had Dr. Iyer back, but due to some travel woes, he will not be able to join us live for this next session, unfortunately. But we're going to have an interactive panel discussion about how you can get involved in patient advocacy and engagement, and then also try to address some of the questions that are down below. So thanks back, Marion and Swapna. Thanks for having us today, joining us today. So there's quite a few conversations that have been happening in the chat, and then there's quite a few questions in the Q&A, but just really wanted to start with something pretty general. And I would ask this of Swapna is, you talked about, the power of using our voice as patients. Have you particularly seen like something that's aspects that are more effective than others, or are there things that, seem to be more effective that we do?
Yeah, I think not underestimating conciseness, but also like confidence in what you're articulating. That took me a while to understand and learn, but really being confident in your message and whoever you're speaking to, if that's email, if that's speaking, if that's writing on social media. I want everyone to be as genuine as possible, but do check your writing and read and how you're writing, because storytelling is so powerful in any medium. And so if you can get your message across with confidence, but with also being genuine and articulating it well, you can go really far.
I agree. So well said. And then I'm going to ask a quick question to Dr. Winkler. At first, I was at Aspen, and you talked about the shared some time frames. I forget the exact numbers, but like 0 to so many years and 10 plus years. I just remember that being really profound to me. Is there any way that you can just quickly share? You don't have to share the exact data on that, but just the essence of that. I thought that was so important to capture that over time our experiences seem to change.
So thank you for that question. I just want to add one last thing to the previous question, if I can, is if you're in a one-to-one scenario where you're going to share information or you have a lot of questions you want to ask, make sure at the very beginning of the encounter, you tell the physician or the practitioner you have questions so that they save time for you. So in my research, I had 24 people I interviewed, and I purposely recruited them based on their length of home parenteral nutrition dependency. So I had a small group that was less than 2 years, and this was guided by work done in or other research. So there was some I guess rationale for these categories of time is the best way for me to say it. So I had some less than 2 year people, some 2 to 5, 5 to 10, and greater than 10. And in the greater than 10 years of HPN dependency, there were 2 that were longer than 25. And so the people in the less than 2 years basically talked about their experiences compared to what their life was before their illness or their need for PN. And their understanding and expectation was that this was a temporary therapy and that anytime soon they might be having surgery or having something done that they would no longer need PN. In the 2 to 5 years, there was a beginning to understand that my life is different than it was before. In the 5 to 10 year group, there was this acceptancy in some ways about understanding the need for PN, establishing a new normal, like Swapna talked about, like some recognition that this is the way my life is, and I want to focus on what I can do and not what I can't do. In the longer than 10 years, there was obviously acceptance that this is my life, but it basically the longer time on, and especially the people for the 25 years, they felt like they were in uncharted territory because nobody could really tell them what was to come. So there was this, you know, I don't want to say concern, but there was a recognition that they really are going to teach everybody else what life is like with long-term survival on PN. So it was very, very interesting. But in my understanding of the literature to date, there is very little research looking at repeated measures over time to actually take the individual and study them over time and see those if quality of life changes. I hope somebody will do that.
Well, thank you for that. And I remember, thank you for sharing that again. I remember sitting there thinking, yeah, that was what I was doing at 0 to 2. And then you shift to 2 to 5. Well, yeah, that was my experience too. And then the same thing, like my son has been, you know, has intestinal failure and he has been on PN for almost 12 years now. And it was exactly, mine fit that same thing. I don't know that everybody's will, but I found it quite interesting and I had never really considered that before. So thank you for highlighting that today. One of the questions is, or it's actually a statement, but I like to turn it into a question, is about how we could potentially even use this as an EN measure and not just PN. Do you have some thoughts on that?
Well, you know, my work in developing this questionnaire was totally based on adults receiving home parenteral nutrition. And so the first phase of it was those interviews and then trying to capture the general themes that I was hearing. And then that established the framework for which to write those patient-reported outcome questions. So that, and then all the testing was done among adults with intestinal failure, although the population of home PN dependency gets broader as the studies were conducted and the validation work was done. So it cannot be generalized to pediatrics. It cannot be generalized to, say, other conditions that might require PN that aren't intestinal failure. And you know, from a research perspective, it's not generalizable to home enteral nutrition, but certainly the questions can be modified and can be used. And I know that some of the people who are participating in this audience have a lot of interest in wanting to do that for different populations. So I think certainly the conversation can be structured around that with any type of therapy. But you know, from a research standpoint, it's only been tested in that very narrow population.
I think it's an interesting perspective though. Like, for example, my dad has end-stage heart failure right now. And so I can look up some measures and say, hey, not all of these things might apply, but there's a, you know, quality of life measures. This is probably the closest I've ever seen for, you know, all things, not just parenteral nutrition. And so while she's saying for research purposes, it can't be generalizable, but that doesn't mean you guys can't print it out, take it to your doctor and help have that conversation with them. And it's the beginning of the conversation. We may not be able to use it for research at this point, the results. That's really what she's saying, but please modify it.
Yeah, and there are a lot of research is used with generic health related quality of life instruments. So people may have things they fill out, but I think what we did learn in the last 20 years, the importance of disease specific or therapy specific tools, and as Swapna and the Gutsy perspective projects are focusing on, you know, from the grassroots up in trying to design that to capture the experiences that really people are facing. So I think that's very, very important. And in addition, there are other things. There's a coping well home enteral nutrition I don't know what to call it, a manual that was designed based on similar type of work by Dr. Cheryl Thompson. It's old now, but very valid. And that did focus groups and interviews with home enteral nutrition consumers. And she's got a checklist of all kinds of things that can be used. And I tried to incorporate some of that into the previously recorded talks.
Absolutely. Well, thanks for sharing that. And along those same line, while we're still talking about the tool, it says have you seen this tool as useful for helping clinicians learn to encourage the flexibilities patients need to have for improved quality of life? She says it seems that often those who are more conservative or restricted are reflecting the training and fears they've learned from clinicians.
Yeah, there's so many things in that question that it just sparked me wanting to talk about. First of all, when I first presented the data, clinicians said, if they found their patient was manipulating the times or changing things, that in many ways that gets interpreted as non-compliance. And I said, I think it is more flexible. And so I agree. I think there has to be a lot of clinician education about what can be done and how the therapy can better be incorporated into people's lives instead of the way we prescribe it or recommend it be done. And that is across the board in both parenteral and enteral nutrition. I often say that some of the administration and infusion schedules that we do in the hospital really are not conducive to doing at home, but we're kind of stuck in that medical model. So I think really it should be a conversation. And if the clinician whom a patient or consumer is talking to doesn't feel comfortable doing it, then I think that, there could be a recommendation is, well, could I get a second opinion? Could we talk about other people? Maybe you might want to talk with a clinician, another physician or clinician who I know is managing a friend of mine this way. So there's ways to engage in the conversation, even if somebody doesn't feel comfortable.
Absolutely. And I'm going to throw this question to Swapna in just a second here, but there's even things like, changing in the time of the year. Twice a year, we forward an hour and we back an hour and things like that. And that's never in the 12 years we've been on parenteral nutrition has never even been discussed of how do I handle that? Do I go up by 15 minutes every day and I'm there? Nobody's ever brought that up. I just figured it out on my own. Or things like we're about to go to surgery and it's, 10 o'clock in the morning and he's got a 2-hour ramp. Well, what am I supposed to do? And I've come up with some things that I'm supposed to do, but it's just, those are conversations that we need to have. And I quite bluntly, at least in my case, and maybe you guys have better teams than I do, no slight to the teams that I'm talking to, but they say, I don't know, talk to the next person, and they kind of pass it down the road. So Swapna, that same question to you, basically, what are some things that you've had to do, things that you've done on your own versus talk to your clinicians about, or what's that balance there?
So I mean, advocating, one of the things I've talked with Dr. Winkler about in terms of advocating, one tip I've learned in adulthood is, even though I speak for a living and do public speaking, I get very nervous in clinic appointments. It's intimidating to an extent. Sometimes there are situations where we're only looked at as patients, period, and it's unfortunate. And so I write everything down. And that piece of paper gives me the ability to talk, or like my notes, or I've even done a patient reported summary, but also including like my desires or the desire to have a team that works with consults, or I need you guys to manage nutrition and hydration, but surgery is being managed by a different team, or this is the model that we have in place. This is what we need you to do. And I just say it bluntly. But that has come with time and interacting with different providers through their Oley Foundation conference, meeting the speakers who speak at these conferences. A lot of times there are the experts in the field. But then in terms of more personal day-to-day care, there have been a lot of situations where at this stage in life, I'm very much in the uncharted territory. It may be unique to the fact that I'm alive, having been born in 1989, and the history that I've had, but it's not unique to the experiences of fragmented care, unfortunately. So as a family, we've had to do a lot of thinking on the spot are utilizing local providers. And so I really encourage, although the importance of subspecialty multidisciplinary care teams that we've talked at length about today is crucial, I think, to the care and outcomes in intestinal failure. I think it's also very important to have a local team that is flexible to you as a patient and family and understands you as a patient and family know you best, where so you have the flexibility of having some autonomy. So we've been in situations where we've asked providers, can you order this x-ray, versus provider saying we'll order the x-ray, or provider dictating versus patient and provider shared decision making and then dictating. And that's how we
Absolutely.
get this far. And without vascular access, I mean, there's a lot of things that I've just have no more options, where we have to be very creative in the system that we have. Otherwise, I would be stuck in a hospital bed.
I think that another opportunity, since these therapies, the home enteral and parenteral nutrition, are really, for the most part, coordinated and monitored and managed by home infusion providers, that could be a valuable opportunity for them to advocate to the prescribing physician on your behalf. So I think that you have a tendency to find more expertise and knowledge among, the pharmacist or the dietitian or the nurse in the company, who could make the connection directly with the physician to help bridge that conversation and topic. The other thing, and Dr. Iyer certainly dropped a little point about advocating to your clinician or your physician to ask the question and present your case at an ECHO meeting. And I think that is the best way. I think Swapna said it, and I sort of hinted at it too. But I think that, we want to try to reach out, because we think this is a valuable education opportunity. And the people who tend to come are people who have knowledge and experience and are interested in intestinal failure. So how do we get at that, physician prescriber who only has 1 or 2 patients with intestinal failure? And I think the patient could say, oh, I learned about this Learn Intestinal Failure telementoring program. There's an opportunity to present case. Would you be willing to present this case and ask on my behalf? I've heard many presenters, so other clinicians presenting a case, say that they told the family or the patient that they would be presenting their case anonymously. We've told our patients we've presented and asked those questions, and then we come back with them to the answer. So I think that is the best way to really start bridging this. How do patients get involved in Lift Echo?
It's funny you say that, because I literally made myself a little sticky note over here and put it on the side during his talk that says, talk to Dr. So-and-so, my doctor, about Lift Echo. So clearly I even need that. My son's the only one she manages here. It literally. So, and the last conversation we had with her was not about quality of life, though I had that in my head. So I was asking her some of those questions or sharing some of those things with her without the QL data in front of me.
Yeah, everything, the case presentations go from, diet to transplant and everything in between, management, vascular access, for other medications, research study. I mean, it's the whole continuum of management of intestinal failure. Not every case discusses every single element of that. So.
No, the
right,
dynamics
absolutely.
they're very powerful. And that is something as a team that we're considering and hoping to do more of, is grassroots campaigning to bring more awareness of Lift Echo to the patient, to then educate their clinicians, because that side of it, this is just one presentation, and hopefully we can continue to do posts and other things to bring
it reminds me, I had a graduate student a couple of years, it's probably 10 years ago now, who did a qualitative interviews among home parenteral nutrition and home enteral nutrition consumers that she recruited through Oley, and it was designed, the study was really to try to get an understanding of the value of Oley. And her findings, there were many, but one that really jumps out is the consumer as the educator of the clinicians. And I'm sure many of you have had that experience in terms of sometimes nursing and home care management and how the line is handled and various other things, but you as the consumer are often educating the clinician because you're learning in this environment.
Absolutely. Well, and I know this is a little bit out of order here, but yesterday and then again today, there's a couple questions about, what is intestinal failure? And I can tell you, even at Aspen, I had several conversations with several different doctors, and they all have different definitions of it. So what is intestinal failure?
So, I don't have the actual published definition right here in front of me to read, and there are those things, but basically it's not having enough functioning or length of intestine to adequately support nutrition and hydration needs. So that's where this dependency on home PN kind of gets stuck with that definition. Now, pediatrics has a very specific definition, and if Savan is here, maybe she can pipe on and give that, but that one actually has time frame embedded in the definition in terms of the length of time dependent on PN. But basically, intestinal failure is when you can't support yourself by food and fluid alone.
And then one question on here is, what's the beginning symptoms of intestinal failure?
Well, there are many etiologies or reasons that people end up with intestinal failure. So surgery that leaves somebody with not enough intestinal surface area. So that could be acute. There could be a problem with blood supply to the intestine, and there's severe abdominal pain. Somebody ends up in the emergency room and gets emergently taken to surgery and wakes up and learns that they have short bowel syndrome or intestinal failure. There are inflammatory bowel disease related etiologies, so that if somebody has longstanding Crohn's disease or other inflammatory bowel that's required surgery over time, multiple surgeries could get you to that point. There could be malabsorptive symptoms, and then there are a lot of the childhood disorders, necrotizing enterocolitis, gastroschisis, Hirschsprung's, and some of those things that lead to it. But I think in general, most people have diarrhea, weight loss, dehydration, malabsorption, maybe some unusual vitamin and mineral deficiencies or very specific electrolyte deficiencies, and everything in between.
Thank you. So as we wrap up a little bit here, I'd love to, I'm going to give Swapna and Marion a chance to say any last things that you want to say here. So Swapna, you first. If there's any comments, questions, whatever you want to share, here's your chance.
Well, no, thank you for having us. And this is just the beginning of sharing more about Lift Echo and how the Oley community can get involved. And again, I really want to harp on how you really can advocate at any point in your journey, and advocacy can evolve throughout your journey. As I shared, I started in one segment just trying to connect with different organizations, and then now I'm more into the research side, but it can work for any place you are in your disease state, as well as for your passion. So please don't have any fear in speaking up. It's very, I think, an innate part of us, and you're very validated to do it and to share your voice.
Thank you for sharing your voice, Swapna. You're always such an inspiration. Thank you so much. And then Dr. Winkler, a last thought from you.
Well, I'll say something that I'm sure Dr. Iyer would have said, and that is watch this space.
Oh yeah.
There's so much research over the last couple of days. I've got a piece of paper over here that's a mile long of thoughts of that have been coming to my head, maybe next year's conference, things in between here and next year. And one of the themes that comes through is we need a lot of more research in this space. We need a lot more advocacy in this space, and we need everybody's all hands on deck. So thank you so much for joining us today, Dr. Winkler and Swapna. Thank you so much.